Today's topic, we're just going to pass through the acute chronic rhinosinusitis. And in this lecture, we are going to cover the anatomy of the nose, the classification of rhinosinusitis, the etiology, the presentation, the diagnostic steps, treatment, follow-up, and complications. The anatomy of the nose is very simple, where we have the external nose and we have the internal nose. The internal nose is just the nasal cavity. And in the internal nose, we have the nasal concha or the turbinates, which are three of them: the inferior, middle, and superior. And below these turbinates, we have the opening of the sinuses, which are called the meatus. So in the lateral wall, there is where we have these turbinates, as I've mentioned, where we have the inferior, middle, and superior. And then below these turbinates, we have the opening to the sinuses among lacrimal duct. So the inferior meatus usually serves as an opening to the lacrimal duct. The middle meatus serves as an opening to the frontal anterior ethmoid and maxillary sinuses, whereas superior meatus serves as an opening to the posterior ethmoid sinuses. This is an important which can come in as an MCQ, whereas the sphenoethmoidal sinuses serves as an opening to the sphenoid sinuses. So among the sinuses, the frontal, maxillary, and sphenoid are paired, whereas the ethmoid sinuses are just multiple and unpaired. So before we begin classification on sinusitis or rhinosinusitis, what is rhinosinusitis? Just from the name, rhino means nose, sinusitis means sinuses. So this is the inflammation of the sinuses and can also lead to inflammation of the nose just because they are in close proximity. So classification of sinusitis, we have the acute sinusitis, we have subacute, and we have chronic. So in acute, just from the name, this is when you have signs and symptoms lasting less than 4 weeks or lasting less than a month. In subacute, this is when you have signs and symptoms lasting 4 weeks to 3 months. So 1 month to 3 months. In chronic sinusitis, this is when you have signs and symptoms lasting more than 3 months. So I hope you are good with that. So the pathogenesis of rhinosinusitis is very simple. As we have said, rhinosinusitis is an inflammation of the sinuses. And obvious, we have to have a trigger. And the first trigger that we have, or where we are going to begin this cycle, is the infection. Where we have an infection of in the sinuses, and then that inflammation will lead us to have inflammation. And obviously, you know the markers of inflammation, right? I hope you know. And then through those markers, you're also going to get signs and symptoms. So after the inflammation, then we are going to lead to edema. And then in the edema, because already edema kind of causes distension, then we can have the sinus ostia then closed. Sinus ostia, this is the opening to the sinus that will lead us to the meatus. So if we have the sinus ostia closed, we will also have, or the high increased possibility of us having blockage of the osteomeatal complex in the middle meatus. As we said before, that we have three meatus in the nasal cavity, where we have the inferior meatus that just below the inferior turbinate, the middle meatus just below the middle nasal turbinate, and the superior meatus just below the superior turbinate. And we say that the middle meatus drains almost all major sinuses except the posterior ethmoidal sinuses. So if it's those, then it will have blockage of the osteomeatal complex in the middle meatus. And after you have now the blockage of these sinuses, and meaning that we have inflammation in these sinuses, we have infection in these sinuses, we have edema in these sinuses, and the ostia is closed, meaning we cannot get the contents of the sinuses out, then we lead to then more bacteria colonizing there and replicating. In addition to that, after we have that bacteria replicating there, then we're also going to have ciliary dysfunction. And what's the work of the ciliary, which helps us push mucus out of our places. So for example, then in our sinuses, we are going to have blockage, we are going to have replication of that bacteria, and we're not going to remove these contents out. So that will also result to the mucosal edema and also a continuous cycle of infection, inflammation, edema, sinus ostia, blockage of the osteocomplex, colonization of the bacteria, ciliary dysfunction, and mucosal edema. I hope you have understood. So etiological organism, that the organism causing these our infections, we can have the viral, which is the most common. We can have bacteria and anabacteria. The most common one we have is strep pneumoniae. We also have alpha and beta hemolytic strep. In addition to that, we have non-typeable Haemophilus influenza. And the reason behind this is because we usually vaccinate the typeable, that is the influenza B. So in addition to that, you can also have fungi, and this is most common in immunosuppressed individuals, such as patients who have diabetes mellitus, who have HIV and AIDS, or who are undergoing organ transplant. So the risk factors usually have local risk factors and systemic risk factors. So in local, we usually have a patient who comes in history of upper respiratory tract infection, allergic rhinitis, nasal septal defects, aspiration of infected water, barotrauma in terms of diving, nasal foreign bodies. We also have nasal tubes, dental infections, overuse of topical decongestants, nasal polyps or tumors, and smoking. So in systemic, this is usually things to do with the immunity mostly. So we have diabetes, we have immunocompromisation such as AIDS, malnutrition, long use of steroids treatment, blood dichrasis, cystic fibrosis, and chemotherapy. So clinical presentation symptoms usually progress, signs and symptoms usually progress over 2 to 3 days after the infection. So after you have known the pathogenesis, which is just very simple, as we said, you have infection, inflammation, then you have edema, you have occlusion and blockage of the osteomeatal complex in the middle meatus, because this is where most sinuses usually drain. Then you usually have colonization of the bacteria because you're already closed. It's like a blocked system. And then this will lead to ciliary dysfunction and then cause mucosal edema and then infection. And then the cycle continues. So from the pathogenesis, this is where just you're going to enlighten the signs and symptoms, because signs and symptoms are just a reflection of the pathogenesis. So in terms of inflammation, obviously you're going to have markers of inflammation, and you're also going to have things to do with malaise. They'll also have malaise that is fever. They're also malaise that is fatigue. They're also going to come in with fever, and this is mostly indicative of bacterial infection. They're also going to come with headache, and this type of headache is usually office headache, which starts in the morning, but around 10 a.m. the headache has almost subsided. So as we said, you're going to have edema, therefore you're going to have edema, therefore, and also mucosal edema, therefore in the nose you're also going to have nasal congestion. So in addition to that, we also said we are going to have colonization of the bacteria, and which is going to replicate and mark that if we have infection of the maxillary sinuses, which are almost close proximity to the mouth cavity, therefore in that association you can also have halitosis. And just to explain this is because most of our canines have their roots in these sinuses. So when you have tooth extraction, then most times then food can pass through that our mouth cavity to our sinuses, and in the end causing a patient coming in with halitosis. So rhinorrhea, this is when you have a discharge of in the nasal cavities, then could be purulent in bacterial infection. Kindly note, rhinorrhea will be absent where we have complete blockage of the osteomeatal complex in the middle sinuses, meaning you don't have flow of substances, or you don't have flow of this purulent discharge from the sinuses to the nasal cavity. So as I've just mentioned, we said the etiology, we have bacterial and we have viral. Viral is the most common. And in bacteria, which bacterial did we say? We said strep pneumoniae, we said after alpha and beta hemolytic strep, and then we said non-typable beta hemolytic. Sorry, non-typable influenza. Sorry. So for bacteria infection, how will you know that this patient is bacterial infection? Number one, we usually have something known as double sickening. And double sickening is when a patient comes in with common cold, and then after some small time, those symptoms kind of subside, and then later now have an increase in the symptoms after 5 days. So they came in with signs and symptoms of common cold. The common cold seems to subside, and then later, then it increased. The same signs and symptoms increased. That is what is called double sickening. So if a patient comes with this kind of history, then you highly suspect that this is bacterial infection. In addition to that, that is just what I've said. So signs and symptoms subside and then worsen 5 to 6 days. So these are pointers to secondary bacterial infection. In addition to that, when you have three these of the following, you highly suspect bacterial infection. And this is when you have fevers above 38 degrees, which I've mentioned before, when you have double sickening, which I've also mentioned, when you have unilateral disease, meaning you have blockage of one nose among that, when you have severe pain, and you have when you do your lab, when you have elevated ESR and CRP. So what are the clinical examination? As I've mentioned, just from the pathogenesis, this is just what you are going to elicit. So you are going to have erythematous and edematous nasal mucosa, and this is because of the inflammation. You're going to have pleural secretions from the nose. This is kindly note this will be absent if the meatus is fully closed, because you don't have a flow of things from the sinuses to the nose. When you percuss, there will be pain when you percuss the sinuses. So percussion tenderness, over the sinuses involved and over the maxillary molar, or with the premolar tip. And this is what I was explaining, where you're going to have the halitosis, in addition to fever. Signs of complicated acute bacterial rhinosinusitis. So I'm going to make a slide on the complications of bacterial sinusitis, and we classify them according to cranial, orbital, and local. So in cranial, you can have the spread of infection to the meninges and presenting as meningism. And what are the triad of the meningism? Where we have headache, next, nuchal rigidity, go and find the other one. So in addition to that, you can also have nerve deficit and also loss of consciousness. In addition to that, you can also have this infection spreading to the brain, or you can have brain abscesses, which could be epidural brain abscesses and extradural abscesses. So in the eye, we are going to also have periorbital, frontal, and cheek edema. This is when you have the infection spreading into the eyes. In addition to that, you can also have vision loss and double vision and proctopsis. So investigation, currently know this is an infection, so just don't go panicking. You just do the basic test, that is the hemogram. Then in terms of neutrophils, they will be elevated in bacterial infections. Inflammatory markers will also be elevated in bacterial infections, where we have elevated ESR and CRP. You can also do culture of the sinus secretion. You do this when you have persistent disease. This is not a frequent examination. In addition to that, we also have imaging, and the indications of imaging. These are chronic rhinosinusitis, when you have failure of response to treatment and suspected complications. So you have to note those indications of imaging. And what is the choice of imaging? Where you have CT scan of the paranasal sinuses. So as we can see here, this is a CT scan, and you can see in the sinuses is usually present with black. So this is a normal sinuses, and the left, this we have sinusitis. Whereas this is the same, where in the left it's okay, and the right we have a problem. And the same image you can see in this side it's okay, whereas in this side it's not okay. This is MRI, where we have, as we said, you see the black, it's okay. The place that is not that is filled with mucus, this is the right side. So in terms of treatments, we have aim of treatments, and the first aim of our aims of treatment are going to get them from the pathogenesis. So if it is infection, we'll want to control the infection. If it is inflammation, we'll want to control the inflammation. Because we said the edema and the mucosal edema is going to cause nasal congestion, we'll want to control that. So these are our aims of treatment, and is to control the infection, to facilitate sinus ostial patency and drainage, because as we said here, it's usually blocked. We have the sinus ostia is occluded, and the blockage of the osteometal complex sinuses. In addition to that, we reveal symptoms which include inflammation, which will present as headache, pain, among others, and evaluate and treat from any predisposing condition, and to treat recurrence. So what are these predisposing conditions, which include diabetes? You treat those kinds of conditions. So the general treatment of acute rhinosinusitis, where we have viral. In terms of viral, it's just supportive treatment, where you give pain medication, decongestants, among others. Bacterial, you have to treat with antibiotic. And remember, what are the causative of a bacterial? The etiology of bacteria, we said strep pneumoniae. What did we say? Beta and alpha hemolytics, and the non-typeable influenza, H influenza. So the antibiotic you give is penicillin, that is first line, at least you give for 3 days and can go up to 14 days. In addition to that, you also give pain medication, that is PCM and NSAIDs. In addition to that, you give decongestants, which you have topical and systemic decongestants, and you have ephedrine, you have phenylephrine and oxymetazoline, and this is usually limited to 5 days. And the reason behind this is because it usually causes rhinitis medicamentosa. So list of this is just I've just listed. I'm going to make a whole video on complication of acute rhinosinusitis. So just for you to classify them, just classify them in your head as cranial, classify them as local, classify them as orbital. But just to mention them, you can have mucositis, which is local, osteomyelitis, facial cellulitis, oral antral fistula, orbital cellulitis, cavernosum sinus thrombosis, septic thrombitis, meningitis, epidural, subdural, and intracerebral abscess. Thank